The recording has started now, and I welcome everyone for our 7th webinar in radiology updates. I'm very glad to welcome Dr. Wissam Al-Musawi, who is a consultant radiologist in Carina Hospital and Sutherland Hospital, Sydney, to tell us about the most recent updates in breast radiology. Please, Dr. Wissam.
Thank you so much. Thank you. I really appreciate the opportunity. I'm a general radiologist, and I work at the moment at Sutherland Imaging Center, and I'm a VMO at Carina Private Hospital. I worked for more than 12 years at St. Vincent Private and Public Hospital as a senior staff specialist, and before that, I worked at Prince of Wales Prince Henry Hospital. So I've been practicing here since 1996. But today, I have a special interest with women imaging, like gynae ops and breast imaging. So it will be just a short preview about what we will talk about. We'll talk about some demographics, risk factors, clinical presentation, early detection, screening versus diagnostic imaging of the breast, biorights classification. A lot of general GPs heard about the biorights, probably just a little bit of explanations, and what's the best modalities for breast imaging. Some demographics, probably you're all familiar how common breast cancer is. It's the third most common cancer in women, which comes after lung cancer and of non-melanoma skin cancer. Some women in their life will, 1 in 8 women throughout their life will be diagnosed with breast cancer at some stage. That's 4% actually of women will be diagnosed with breast cancer at some stage of their life. So it's a really a very common cancer. There's a striking difference we notice in the prevalence of breast cancer in different geographic locations. Like, for example, in death rate between women with breast cancers. So in UK, we find death rate is much higher from invasive breast cancer than in Japan, for example. And they think part of that could be related to climate, could be the sort of diet they have, the race, as well. So we know, for example, African American are more prone to have breast cancer than Native Americans. So race also is a factor. We also all know that age is a big factor with prevalence for breast cancer. So the older the woman, the higher the risk of them developing breast cancer. So after the age of 60, the risk is much higher than younger age group. Risk factors, why some women get it, why some women don't. I mean, there's not one factor, it's multifactorial. There's a lot of factors which contribute to it. One of the important ones are hormonal. So, for example, early age of menarche. So if the woman has her period at early age and then menopause at late age, they are high risk. Late pregnancy after the age of 30, so early pregnancy is better. Null parity, so women who don't get pregnant at all, they are at higher risk. We're all aware of family history, so but the important point is if a patient has a mother who been diagnosed with breast cancer over the age of 70, the risk is much less than if her mother was diagnosed with breast cancer at the age of 37. So even family history, the age of first relatives, the first degree relative, when they're first diagnosed with breast cancer is important. Personal history, so if somebody has a breast cancer once, they're at much higher risk of developing a second breast cancer, 3 to 4 folds to develop another cancer in either breast, same breast or the second breast. So previous history of cancer is very important. Also, if the patient has a history of benign proliferative breast disease, also they are higher risk. Other risk factors, obesity, urban residents. So people who live in the cities, they're at higher risk. And they even notice that even if somebody lives in the country, but moves into the urban suburbs, they will increase the risk of breast cancer. And I guess part of that is pollution, diet, lifestyle, it all has effect. previous history of oral contraceptive pills also, and that's especially with the combined pills, which are like estrogen, progesterone combined pills, it's a high risk. Genetic background, this is becoming a big factor now. So patients who have a genetic, are positive for BRCA1 and BRCA2 at higher risk of developing breast cancer. Also exposure to radiation. Sorry, I think I'm rushing because it's a big topic and I need to squeeze it in 15 minutes. So if I'm going too fast, please let me know. I'll slow down. Radiation and dietary. A lot of fat, a lot of alcohol, lack of exercise, all these are factors. So how do women with breast cancer present? So people, a lot of patients, they worry if they get a breast lump. It's the most common presenting symptom for screening mammography or diagnostic mammography. So usually it's a breast lump, which is usually painless. But we need to know 90% of patients presenting with breast lumps, they will end up being benign. So it's not really that worrying of a sign. Other presentation is with nipple discharge, especially if it's a bloody or serous discharge. For approximately, sorry, I'll just have probably to move that. Approximately 10 to 30% of a bloody discharge are associated with breast cancer. The other 90–70% of discharge could be normal physiological phenomena or associated with fibrocystic changes. Sometimes a patient presents with just skin dimpling or sometimes ulceration and nipple retraction. The tumor, if it grows fast enough to invade through the skin, we'll see ulceration and skin irritation. A lot of patients present with breast pain, but breast pain is not a normal presentation for a breast cancer. It's usually due to benign condition, and it's not usually the first symptom unless the tumor invade to the skin and invade to the nerve end. Early detection is very important and very vital for for detection of breast screening. So if we follow the patient with mammography can detect 75% of cancers at least a year before it can be diagnosed clinically. And that's why it's so important to do screening. Just need to move that a bit.
Screening mammogram.
I'll just need to move it a bit. Screening mammogram is recommended for patients over the age of 40. Usually here in Australia, we do it on 2-yearly basis unless there is a high risk factor. But in America, for example, they do it on a yearly basis. And doing it on a yearly basis actually can detect earlier cancers by 19 to 33%. So if we do our screening mammogram once every 2 years, we probably don't detect 19 to 33% of cancers. That's why it's very important to do the screening mammogram, especially after the age of 50, on yearly basis. We do it routinely on yearly basis if there is a family history, if there is a risk factor, if there is a previous history of breast cancer, we definitely do it on yearly basis. That's about it. What if we found an abnormality in the mammogram? Why are we so worried about it? Once we detect, and usually, especially in screening, usually what they do, they send them back for a workup. So we do X-ray views, we do ultrasound, we examine the patients in order to further evaluate this abnormality we find. We found that on additional imaging, 85% of cases which are determined to be abnormal on screening will end up being just a biorite category 1 or 2, which is a benign presentation, like cyst, fibroadenoma, like fibrocystic changes. Only 15% of patients which come to screening and we find an abnormality will show an abnormality which require biopsy, which is biorite 4 or 5. And out of these, which we biopsy, 80% of them will be benign, only 20% will be abnormal. So in summary, only 2% of patients presented with abnormality will end up with breast cancer. So if you find an abnormality in the mammogram, don't worry. the workup will sort it out. And that's why we bring the patient back, we do additional view, we do biopsy. The other important topic I wanted to touch on is missed cancers. Why do we miss cancer if we're doing mammogram and ultrasound? Dense breast is our enemy. It's very hard to, especially in the 2D mammography, to detect breast cancers because it will be hidden behind it. All you see is a white breast. You can't really see calcification, you can't see masses. So that's a big factor. Sometimes technique, like poor positioning. It's very important that you send your patient to a center which see a lot of breast, not screening, I'm talking diagnostic. So a radiologist which is experienced with interpreting images, breast images, and a good center with good technician who know how to do the positioning and how to do the technique. So dense breast, poor positioning, perceptus error. Some radiologists, they don't have much of an experience with breast imaging. Sometimes the cancer is very subtle. It's really hard to say. Even only in retrospect, you can say, oh, here you go, that's it, that's where it is. But even you look harder, and with screening, breast screening, the radiologists usually check the images. And sometimes the lesion is very slow growth. So we do follow up. We screen them in 2 years' time, and they look exactly the same. And you said, okay, it didn't grow in 2 years, so it's probably benign. But it's not the case. They can still be malignant. The false negative rate for mammography is approximately 8 to 10%, and it's pretty high. And that's why it's one of the most common medical legal cases, missing breast cancer, because it's just because of these factors I mentioned. So we talked about screening mammography versus diagnostic mammography. Screening, when you send them to screening center, they don't see anybody, just the technician. And then if you need workup, then they send them back for diagnostic mammography, where we do X-ray images, we do compression magnified views, we do ultrasound, we examine the patient, and we might even need to refer them to a surgeon. So that's the difference. Another important point is a woman with breast implants or personal history of breast cancer will usually require additional views anyway, so they have to go to diagnostic imaging. Just an anatomy picture, just a simple picture, just to, I mean, all of you know that, but the breast made of a nipple, retroareolar ducts, intramammillary ducts, and lobes, which contain many lobules inside. And usually the tumors either intraductal inside these ducts with calcification or lobular, so they develop in these lobules. And you can see the mammogram looks very similar to the anatomy. And that's a pathology form, so that's the duct, and you can see all the intraductal stuff get calcified, and that's where we get the DCIS, the intraductal calcification. And these are the lobules, and has a mucosal outlining where the lobular carcinoma develops. Density, we talked about density of the breast, so now it's mandatory for each mammographic report. We mentioned the density of the breast because it's a very important factor for diagnosis and for missing cancer. So we have a density A, which is a dense fatty breast like this one, and then density B, a bit of scattered glandular tissue, density C, more glandular tissue, and D is when the breast is all white and you see nothing. I'm just going to show you a very simple, straightforward example of what breast cancer look like. So usually it's irregular in outline, it's speculated margin, and where it's dense. And when you see, you compare it with ultrasound images, it's hypoechoic, height bigger than width. You see it's chewing into the breast parenchyma with speculated margin, and it's associated with shadowing, and sometimes it have vascularity. So this is a Barite type 5. So this is a different cancer. Microcalcification, I don't know if you can see, can you see the images clearly?
Very clear, yes, we can see very clearly.
Okay, so this is sort of calcification we worry about. I mean, there's a benign calcification, and we don't worry about it. The one we worry about it the most is when they cluster together, when they're branching, which we know it's inside the duct, when they don't have a uniform shape, when they different sizes and different shapes. That's what we worry about. Breast lesions could be circumscribed or non-circumscribed. The circumscribed or the rounded one, well-defined margin, this is your friend. This is usually benign. It's a cyst, it's a fibroadenoma, it's probably hematoma or sclerosing adenoma. But that's not always the case. So not always when you see a well-defined lesion, it means benign, because phylloidous tumor, medullary tumors, papillary tumor can look very well defined, and they can be very misleading. So that's why we have to do the ultrasound to make sure, is it a cyst or is it a solid lesion? Is it a typical fibroadenoma, or if it's a phylloidous, then we need to decide on doing biopsy or not. So this is a simple cyst. It's a happy, well-defined, all the margin. You have to look at the margin. So if 90% of the margin is well-defined and 10% is ill-defined, that is still something to worry about. Nice enhancement behind it. So with this, we usually leave it alone. Sometimes if it's big enough bothering the patient, we just put a needle and aspirate it. Sometimes you end up with complicated cyst. It could be hemorrhage. It could be end up with infection, abscess formation. This one we usually try to aspirate. Multi-fibrocystic changes, very common finding in the breast. Sometimes you see cysts, but then a tiny little nodule. Once you see a solid nodule with vascularity, you worry about it. It could be intraductal papilloma. So we have to biopsy this, and we have to biopsy the solid nodule. Non-circumscribed lesion, it's usually the bad guys, carcinoma, but it could still be due to abscess, radial scar, or fibrocystic changes. So for example, this looks ugly to me. It's irregular in outline, it's lobulated, it's heterogeneous, but this end up to be just a lactating adenoma. And that's why we have to biopsy these. Intraductal papilloma, you always hear about intraductal papilloma, usually a dilated duct with a tiny little papilla. We have to biopsy these because these could be pre-malignant and that might develop. So this is just an example of how a well-circumscribed lesion can trick you. You look at that and you think it's a cyst, but this is a phylloidous tumor. And if you do the ultrasound, if you do the MRI, you definitely know it's a phylloidous tumor. This is a giant fibroadenoma, and this is a lactating adenoma. They all look alike. Sometimes you can find calcification with ultrasound, and that will make it easy to do the localization and to do the biopsy instead of the stereotactic, but it's not always the case. Every time we do a breast ultrasound, we have to look at the axillary lymph nodes, because we look at the cortex. If the cortex of a lymph node is more than 2 millimeters, we ought to biopsy this lymph node because this could be infiltrative. So we spoke about circumscribed lesion, non-circumscribed lesion, and the third is architectural distortion, which is another very important when it looks like stellate-like lesion. It causes distortion of the architecture of the breast, then you worry about it. But it's a desmoplastic response to a tumor. But it also can be secondary to a scar or a sclerosing adenosis or a radial scar. So we biopsy these as well. And this is just an example of sclerosing margin architectural distortion. And this is a small lesion. It's probably 5 millimeters, but the fact its height is more than its width, it's cutting through the parenchyma of the breast, so it's highly suspicious for malignancy. This is a definite biopsy. When we see calcification in the mammogram and we want to biopsy it, we always put a marker because that makes it easier for the surgeon. When they want to go in and take the lesion out, they know where to go. And then when they take it out, we take an X-ray to make sure that they took the lesion, which we marked for them. And we see the calcification, and we see the margin to make sure they got it with a clear margin, or if they need to go back in again. Male breast cancer, it's not common. Palpable lumps in the breast usually in male is secondary to gynecomastia, which are either secondary to anabolic steroids, to alcohol, cirrhosis, cocaine, renal failure. So it's more usually gynecomastia. But you can still have breast cancers in male. It accounts for only 0.17% of all cancers is men, so it's not common, but each now and then we'll see it as well. How I'm doing with time? I still
exceeded already, but can you wrap up in a couple of minutes?
Just 2 minutes. Can I have 2 minutes?
Yeah, go ahead, please.
Modalities. The only important point I want to emphasize is the importance of tomosynthesis, because we used to have the 2D imaging, which is the ordinary mammogram, but now we're doing tomosynthesis, which is a tube. It's like a tomogram. It's just a tube which make an arc around the breast. We take 15 projections in 4 seconds, add all the data, and give us a 3D image. And then from this 3D image, we reconstruct 2D images. So that by the end of the day, the radiation dose is very similar to the 2D images, and the time is similar because you're only doing the 3D and then you're doing the 2D out of it, and it's very good for dense breast. It's a heaven compared to the old 2D we used to do, because it go through slices through the breast and will look like that. So I know section by section, 1 millimeter, we go through the breast to look at each slide, and it give us much more information. And as I said, exposure, it's not, I'll skip that. We do CT as well to diagnose breast cancer, and we'll also show you mediastinal lymphadenopathy. MRI now is very big with diagnosing breast cancer, especially following up after surgery to see residue, to see recurrence, and for small lesions. And this is what it looked like. And when they enhance and they light up like this, we know definitely it can detect lesions smaller than 5 millimeter. So it's superior to the 3D mammography and ultrasound. It will show you even ducts into the nipple. MRI is very good also for breast implants, because it will show you the internal, external capsule and collapse. As I said, is the most medical legal issue with breast imaging. Thank you so much. I really appreciate your time, and I hope I didn't exceed too much.
Thank you. Thank you very much. That's very informative, Dr. Wissal. And perhaps we keep, to all audience, keep the questions to the end so we can ask all other radiologists as well to show opinions. Thank you very much. For the sake of time, I would have to move immediately to our second colleague, Dr. Rafid Al-Asadi. Dr. Rafid is a consultant radiologist in Westmead Hospital, Sydney, who would kindly tell us about some updates about the imaging and interventions for thromboembolic disorders. Dr. Rafid, could you please share your screen? Dr. Wissal, if you can unshare, it'll be kindly.
Can you see it, or?
Close mine. Shall I close mine?
Do you mind to unshare, Dr. Wissal?
No, stop sharing, of course.
Please.
Yeah.
Okay. And could you share your screen, Dr. Rafid?
Sure. Can you see it, or?
I'm yet to see it, unfortunately. So I can. Have you shared, or you requested a share? Yeah.
I've already done it.
Right. We cannot see your screen. What? So there must be an option for you to share. That's what when it appears.
Yeah, I've done it. Nothing. Yeah.
Okay. Yeah.
Can you skip for the next speaker?
Perhaps I'll skip. So what you can do, you can still try to share, because we allowed multiple participants to share simultaneously. I am not sure if Dr. Ramana can see you. Welcome to our webinar. Are you ready to share your screen, so we can perhaps, just for the sake of the time, for everyone, we would certainly go back to Dr. Rapid once after the presentation of Dr. Nouman Qutaiba, who's a consultant radiologist from Austin Hospital, Melbourne. Dr. Qutaiba finished most of his radiological training in Melbourne, Austin as well, and now he's a practicing consultant radiologist there. Thank you very much, Dr. Qutaiba, for joining us. Could you please introduce yourself to the audience, and perhaps I am happy for you to start.
Yes, can you see my
I can well see your presentation about spine imaging.
Yeah, my name is Nouman Qutaiba. I'm a radiologist in Melbourne. I work 3 days at Austin Health and 1 day at Eastern Health. I do mostly breast and abdominal imaging, but I also do spine imaging, including radiological interventions for spine in both sides. And I'll just present a general talk aimed mainly for non-orthopedic, non-neurosurgical clinicians, mainly from a general practice and emergency perspective, but also to the wider audience. The learning objectives will be common spine imaging modalities with relevant radiological anatomy. I'll talk mostly on degenerative disease with a focus on the cervical spine and the lumbar spine, because those are the two most common presentations to ED and to general practice, with examples from diagnostic imaging and some imaging guided interventions, mainly injections, and a brief note on bone density at the end because of the issue of osteoporosis that's quite common. So degenerative spine disease is extremely common. It's often asymptomatic if you're going to do any imaging that includes the spine. So for example, if you do a CT of the abdomen and pelvis, you will see degenerative disease in the lumbar spine, which is included in that. It begins as early as the age 20. So up to 20% of people by that age will have some form of radiological findings of degenerative disease. And by age 80, about 80% will have that. Doesn't mean that they're symptomatic from it. It just means that it's the wear and tear that starts to happen early. So the radiological findings will always need to be interpreted with a clinical examination findings. So the imaging modalities that are commonly used will be X-rays, CT, and MRI. I will talk about these, and I will let go of contrast MRI, bone scans, PET scans, fluoroscopy, and CT myelograms. These are probably too specific and are done for certain indications. For X-rays, they're a good initial test. It's widely available. It provides information on several important anatomical landmarks, particularly for alignment, vertebral heights, but also for positional and movement changes. So we can do X-rays in supine position, erect position, flexion and extension views, and also just like fractures of long bones, radius and femur. You can follow vertebral fractures and post-op appearances of the spine. Traditionally, we take 3 standard views for the cervical spine. I'll start talking on the cervical spine and give some examples, and then I'll move on to the lumbar spine. These are the standard views, lateral and frontal views, and a dense view of the C1-2 articulation. That's mostly relevant in the trauma setting. In this case, this is an elderly patient. You can already see some degenerative changes in the lower cervical spine. There are some osteophytic changes and narrowing of the intervertebral disc space. And straightening of the lumbar spine, of the cervical spine, sorry. Normally it has a lordotic alignment, which means it's slightly convex anterior towards the anterior part of the patient. These are some new cervical spine X-rays in a neutral position, flexion and extension. These are normal X-rays for this patient. These are done to see if there's any of the vertebrae will slip, or for example, when there's a C1, C2 articulation degeneration, such as in rheumatoid arthritis. Foraminal changes are best seen on these oblique views. As you can see, these are the foramina at multiple levels. The arrow indicates an area where the foramen is narrowed and there's facet joint arthropathy at that level. If you compare it to the level below, the foramen is open and capacious. So this narrow foraminal narrowing is the site where a nerve root is exiting at that level and is likely to be impinged in this location. That's from the bone point of view. If you have disc changes or ligamentous changes, you're unlikely to see them on the x-rays. So we move on to CT, where it is a good initial test, but also a good subsequent test after x-rays. It's very important for trauma, and all emergency physicians rely on that for ruling on spine injury, and it's good for degenerative disease. It's widely available for outpatient and inpatient setting, and it's importantly for GPs, it's Medicare rebatable. It provides information similar to x-rays with more details on the bones, but also more details on the soft tissues, including discs, ligaments, nerves, nerve roots, and to some extent the spinal cord. It's not as good as MRI for soft tissues. It's essential nowadays for spine injections because the majority are done under CT guidance, although some are done under fluoroscopy. This is a sagittal format that's equivalent to the lateral view of the cervical spine. This is in a 45-year-old male patient who's already presenting with some degenerative changes. We can see at the C5-6 and C6-7 levels some disc ossified changes. You can do reformats in the oblique reformats to check the foramina, and on the left side you can see narrowing of the C6-7 and C5-6 and C6-7 foramina. That's osseous narrowing. We can't see any disc material here because it's on the it's a CT scan that doesn't show the disc material very well. And this patient has symptoms related to these foramina and the narrowing, as opposed to the other side. On the right side, they're more capacious. This patient underwent a CT-guided nerve root injection. And with the CT-guided nerve root injection, basically you're positioning the patient on their back, you're asking them to tilt their head towards the other side. You know, you've verified the level where you want to inject. You advance the needle away from the carotid artery and the veins, away from the vertebral artery, which is very close. You get close to the nerve. You don't necessarily see the nerve, where the nerve is, but you know where it will be exiting, and you place the needle and you put some steroid and local anesthetic. So I'll touch on the imaging guided interventions since we talked about this, and it's commonly performed, as I said, under CT guidance. We usually use for the spine dexamethasone and Marcaine as the local anesthetic. In the cervical spine, it's commonly performed for facet joints and nerve roots, as I showed in the slide earlier. With magnetic resonance imaging, so MRIs, imaging of the soft tissues of the spine is very important, and it's essential for assessment of nerve impingement. It's an excellent test for degenerative disease in general. It shows the soft tissue structures, including the spinal cord itself and the nerve roots very well. And it's done in the trauma setting as well for ligamentous injuries. It's available. There is a Medicare rebate for GPs for the cervical spine. Unfortunately, for the lumbar spine, it's not available. The Medicare rebate is not available. And that's where the majority of the presentations are. Lower back pain are very common presentations to general practice and emergency. This is a T2 sequence, and in MRI in general, if you're going to learn one thing about MRI, is that the T2 sequence is the sequence where the fluid is bright. So that's the CSF around the spinal cord. It's bright. This is a sagittal plane T2 sequence, and it's similar to the CT sagittal plane and the lateral radiograph of the X-ray. This person is 52 years old, has degenerative changes at multiple levels, as you can see, C3-4, C5-6, and C6-7 levels. The cord itself is not compressed, but we'll see these changes here on the axial images. So again, this is T2, that's your cord, that's the CSF, which is bright. The fat is always is also bright on this sequence. This patient has left-sided disc changes at this level, but the patient is asymptomatic in this level. So it's very important to know that they're asymptomatic. We're not going to do anything about it. The referring clinician, whether it's a GP or a specialist, don't need to worry about this because they're asymptomatic from this. At a lower level, however, the patient is complaining of left-sided symptoms in the lower cervical spine with radiculopathy to the C6 and C7 nerve roots. You can see radiological changes on both sides, but the patient is complaining of left-sided symptoms, and the same at the level below that, C6-7, radiological changes on both sides, but the patient is complaining of left-sided symptoms. And if you do an oblique reformat or an oblique, acquisition that is commonly performed nowadays in public and private settings for inpatients and outpatients, you see that the foramina at these levels, similar to the X-ray I showed, the oblique X-ray, they're faced with disc material. And unlike this foramen here, where the nerve exists with a bit of CSF around it, the nerves on this level are compressed. And this patient proceeded to have nerve root injections to both levels. They're in a public hospital setting. This is a temporary relief until surgery, if needed, will be performed. Surgery is not always a good option. The surgeons try to delay these surgeries as much as possible. I'll move on to the lumbar spine and also talk about the modalities. We have the X-rays, we have the CT in the middle, we have an MRI again. And again, the X-rays will show your alignment, you show vertebral body height. We already have a minor wedge compression fracture, which is all at L1, which is evident on the X-ray, evident on CT and on the MRI. This patient also has malalignment in that the L5 vertebra, you can see it on the X-ray, is anteriorly slipped. There's anterolaesthesis on the S1 vertebra. And that can be seen on the X-ray. So that gives us good information on that as a good test on CT as well and on the MRI. The MRI doesn't show canal narrowing at this level, but this patient has some nerve root impingement and foraminal narrowing at the L5 S1 due to this slipped vertebra. The X-rays can be done with flexion extension views, and these are usually done such as in this young patient with lower back pain for what we call a pars defect. You will see that in reports of many scans, CT, or several scans of many patients. These include X-rays, CTs, and MRIs. It's a common incidental finding, not always necessarily a symptomatic one. This patient doesn't have slippage on the flexion or extension views. You can see that interruption in the pars articularis, which is the articular process of this vertebra, usually at the L5 level. That can cause some pain. Nerve root impingement and nerve root compression in the lumbar spine is a very common one. This is a 32-year-old male who's already had laminectomy at the L5 level a few years ago, represented with nerve root compression symptoms. So right L5 radiculopathy. And you do the MRI and there's disc herniation or disc prolapse with some extruded material, as you can see here on the axial image on the right side. If you focus on the left side, that's the nerve root going in, traversing in this region without compression. The nerve root on the right side, you can't see it because it's completely compressed. Now, this patient will potentially require repeat surgery. However, neurosurgeons, orthopedic surgeons in general are fearful of repeating surgery on a spine that's already been operated on because of a lot of scarring and potential for recurrence. So we did a nerve root injection under CT guidance. You advance the needle close to the nerve and you confirm that with either a bit of air or contrast, and then you inject some steroid and local anesthetic. This is the diagram that shows that with the needle coming in close to the nerve. We're away from the spinal canal itself. Canal stenosis is very common, and this is an 83-year-old male patient with claudication. So they're coming with symptoms. Their MRI shows stenosis at multiple levels. Now, how do you treat this patient? Depends on whether you need surgery or not. You try to shy away from surgery. At this age, they may have comorbidities. So you try to address this with an epidural injection. Again, this is done under CT guidance, where you advance the needle outside the thecal sac and in the epidural fat, you put in some steroids and local anesthetic. This is another patient with canal stenosis. And again, the thecal sac is markedly narrowed. And again, CT-guided epidural injection. There are several conditions where radiological interventions cannot help. This patient here, for example, has a pars defect, similar to the one we showed with the x-rays. It's a young patient, has tried multiple injections of different nerve roots and facets, and the pars defect itself. The nerve root itself is not compressed. Most of the pain is probably mechanical, and it's arising from this. And this is a stress injury that's happened a while ago. So it's a fracture that's happened, and it keeps giving them pain. They may end up requiring surgery to fix this level so it doesn't cause any symptoms with movement. And also young patients can have disc prolapse and herniation with extruded disc material, not from degeneration, but more from an acute injury, such as lifting heavy boxes or doing some heavy manual work that requires bending. This patient presented to emergency with bilateral leg weakness. This is the lower part of the cord. This is the chordae equina, and this is the thecal sac. And that's how narrowed it is, with extruded disc material compressing the thecal sac. So this was a chordae equina compression syndrome, and the thecal sac is narrowed here, and that's all disc material. This patient required decompression and removal of this material within 24 hours from this MRI from presentation. So imaging-guided interventions in the lumbar spine can be done for nerve roots, epidurals, but also for facet joints. There are other types of interventions, and I'm not going to talk about them because they're very specific and they're probably last resort, and after several other issues have failed. Other interventions such as vertebroplasties, they're done by radiologists. They're a bit still controversial, and that's for compression fractures. Finally, I'm going to talk briefly on bone density, simply because we're talking about the spine, and vertebral compression fractures, fragility fractures in osteoporotic patients and osteopenic patients, as well as normal bone density patients, are common. It's a systemic problem. There's a reduction in bone density and in bone fragility that increases with age. So bone density reduces with age. It's more common among postmenopausal women. And unfortunately, it's often diagnosed after a fracture has occurred. It's a bit too late. We want to be proactive in this. We want to diagnose it early. And unfortunately, in Australia, the Medicare rebate to screen for osteoporosis using a DEXA scan is not until later in age, until 70. So before that, ideally, patients will get a DEXA scan done. It's a relatively cheap test. It's under 100 Australian dollars. So in my opinion, GPs should be offering it to almost all postmenopausal women, as well as anyone above the age of 50. This is what you get. You get a bone density assessment, bone mineral density assessment of the spine and the femoral neck. It can prevent some serious complications such as distal radial fractures, vertebral fractures, and importantly, hip fractures. And that's my talk. Thank you. I hope I stuck to the time limit.
I think it's reasonable. Thank you, Dr. Qutaiba. A very good lecture, very good coverage. We perhaps once again leave the questions to the end. Let's go back to Sydney. Dr. Rafid.
Can you try it now? I've already done it. Okay. Can you see it? Can you hear me?
I can hear you very well, yes. And
can you see the share now or not?
Dr. Rahman, can yeah, okay.
Yes, I can.
All right,
see
yes.
Yeah.
Perfect. So we can see Dr. Rafid, we can see your presentation.
Sorry for
once
this
again.
technical. I'm just trying every computer in my house. So
no,
I have to...
no problem. And so for once again a gentle reminder of the 15 minutes
Sure.
time allowed, so we can cover. So go ahead, Dr. Rafid will talk to us about the recent modalities in diagnosing and perhaps more intervention about thromboembolic disorders. Go ahead, please.
So I'll mainly talk about the intervention of thromboembolic disease, in particular the PE, because the end result and the fatal results will be PE in most of the thromboembolic disease. My name is Rafid Al-Asadi. I'm one of the staff specialists, a senior staff specialist, intervention and diagnostic radiologist, Westmead. I'm VMO in Nepean Hospital, and I have the Arab Board of Radiology, Fellowship of Royal Australian and New Zealand College of Radiologists, and also I have the European Board of Intervention Radiology. So now, is it moving or? Oh yeah. All right.
It's
So yeah,
yes,
this lovely picture. Sorry for the picture, but this picture had been taken at 4 a.m. When I was on call. I've been called to deal with a gentleman, a young gentleman with submassive pulmonary embolism, background of a complex spine and brain surgery, and they don't have any options. They called me, can you offer something? I said, yeah, okay, coming to the suction thrombectomy. And this is the amount of the clots I got outside from his pulmonary circulation, and the oxygen saturation went up from 80 to 94, and he did very well after that. So thromboembolic disease is one of the major causes of death, and thromboembolism is multifactorial and can affect any organ in the body. Just I'll go quickly through this graph. Cases of DVT and pulmonary embolism by gender and age. So it's most common female and it's most common in this age group between 70 to 79. And it costs lots of money. So in 2008, they did financial assessment, and the cost was about 1.7 billion. And thromboembolic is one of the 5th major cause of death, coming after coronary artery disease, stroke, and lung cancer. So whenever we deal with thromboembolism, we always mention D-dimer. So what is the D-dimer? D-dimer is a fibrin degradation product. It has 95% sensitivity and 50% specificity. It can be false positive by old age, pregnancy, operation, trauma, and cancer, and can be false negative by early, late, and sample insufficiency, and when the patient is on anticoagulation. The factor that can cause thromboembolic summarized in this graph. So either due to endothelial damage, hypercoagulability, or stasis. Among the hypercoagulability, either hereditary or acquired. And acquired could be cancer, chemotherapy, and so on. TBA and thrombosis, which is tissue plasminogen activator and thrombosis. So patients with DVT and PE, they do have depressed endothelial TBA stores. And this is the mechanism of TBA. So the TBA, tissue plasminogen activator, they attach to the thrombus and the plasminogen, and then lead to activation and formation of the plasmin. And the plasmin will dissolve the fibrin in the clots. Imaging of the thromboembolic disease, we do have ultrasound. Ultrasound is cheap, available, and radiation-free, but it cannot examine some parts in the body, particularly the chest. So it's not quite useful for patients with pulmonary embolism. VQ scan is an excellent tool, but VQ scan is not available in every hospital, and it's not available 24 hours. CT scan is an excellent, but it has a radiation hazard. Also, we do need to use contrast. MRI is an excellent, but MRI again is not available in all centers. Clinically, when we do assess the patient with the pretest probability, so anyone with low will do D-dimer, and if D-dimer negative, that's it, nothing to do. If the D-dimer positive, we need imaging. Imaging for DVT, we normally do lower extremity ultrasound. If it's positive, we'll treat. If it's negative, we'll repeat the ultrasound. If high or intermediate, we'll go directly to the imaging without doing D-dimer. And for pulmonary embolism, we do CT scan or VQ scan. If it's positive, we'll treat. If it's negative, we'll do angiography or VQ scan. In US, so I wasn't able to find exact figure, the annual incidence of P in Australia. So I found, different figures, but in US, I found that it's about 600 cases annually, which is a huge number. And about 100 to 180 PE related death annually in US. PE is the most preventable cause of death among the hospitalized patients. The most important slides in my talk, this slides. So it's a busy one, but it's not the most important one. Anyone coming with the patient with PE, we have to stratify what the degree of the PE is. That massive, submassive, or minor. Massive PE means that the patient, they do have sustained hypertension with a systolic pressure less than 90 for more than 15 minutes, and they do need inotropic support, and there is persistent profound bradycardia. The heart rate is down 40, and there is sign or symptoms of shock. Moderate submassive PE, they do have system, they normotensive, but they do have evidence of RV dysfunction and myocardial necrosis. Minor, they just, they behave normal.
يعني ما خبره علاوي اذا خبره يعني بدأ يجاوبهم.
Dr. Rafid, can you unmute please?
يعني هذا بجانب قبل الزواج، زين بعد الزواج شلون؟
Hello?
I can hear you well, and that is a message to everyone. Can everyone mute himself while the lecture is going, please? Go ahead. Sorry for that, Dr. Rafid. Go ahead, please.
No, that's fine. So routinely we do CT scan or echocardiogram for every patient coming to ED. And this is the heart, and we normally measure the RV, which is right ventricle diameter, and LV diameter. And this ratio should be less than 0.9. If the ratio more than 0.9, then there's features. This is a feature of RV dysfunction. And also we assess some enzymes, and troponin or BNP, and we do ECG, and we do have some changes on ECG. We're lucky that the percentage of the massive PE among the population is only 5%, but the mortality rate, it's too high. It's about 58% mortality rate. And to be honest, most of the patients, they've already died before they come into the hospital. Submassive PE, it's 40% of population, which is a good number, and mainly we target this group of population. And minor PE is 55%. I'll skip that one. And as I mentioned before, the RV-LV ratio is an important indicator for the mortality adverse events on recurrence of the thromboembolic. So it's busy, too many slides. Okay, so now what the dynamic behind using the IV thrombolysis? So imagine this is the clots in the pulmonary circulation. So this is the main pulmonary artery, left and right. So this is a clot. As we know that the thrombolysis won't destroy the clot, but to prevent further events. So the drug will come in here, and then by the turbulent flow, it will come back to the normal side. So basically we're not doing anything. So what we do, we choose venous access either through the jugular or femoral vein, and then we'll go through the IVC or SVC, and then through the heart, we'll put in a catheter into the right, and in the right and the left pulmonary artery, and then we'll start treatment. Treatment either by thrombolysis or thrombectomy. I'll talk to this about this soon. So this is the machine that we use it for thrombolysis. It's coming with a generator and has an ultrasound wire, and also it has a catheter itself. I remember when I was fellow 2014 in Westmead Hospital, we've been called to deal with a case with submassive PE, and then I said, oh, that's exciting. Let's go home, do some study about it. And then I found that in the US, they've already established a service which is called PER team, so Pulmonary Embolism Response Team. It's a kind of similar to the stroke call. So next day I went to my boss. I said, oh, look, in US, they do this kind of service. He said, oh, that's a good idea. Let's start it here in Westmead. So we called respiratory, emergency, ICU, hematology, and other relevant team. And then we had a discussion with them to establish this service in Westmead Hospital. And It is a multidisciplinary team available 24 hours, first established at Mass General Hospital in US. And I think in Australia, Westmead was the first and probably the only Australian site to date. And this kind of normal, simple card that we leave it the switchboard, and you can see my name among the team. So any patient come in, we have to participate in the phone call. Sometimes it's a nightmare. They call you in a 1 a.m. or 2 a.m. and you have to pick up the phone to discuss the case. So what we normally do, we diagnose the case when it comes to ED by CT scan, and then we call the PER team and then plan on that way. Establish the diagnosis, whether this is just a primary PE or maybe secondary. Secondary means due to the underlying malignancy, and then treatment plan, which way we have to go. And then we'll decide whether the patient will go to the ICU or HDU. And this is an example of, submassive pulmonary embolism. You can see the clots there inside the contrast, inside the main right and left pulmonary artery. And this is the RV-LV ratio I mentioned before. So for access, we tried many things. We tried 2 sheath, and then we found this kind of sheath. We asked for it. It's coming from US. It's 12 French sheath. It's a big sheath. We go through the jugular or femoral, and it has 3 ports. We use two of them for the right and left pulmonary artery if the patient has bilateral PE, and the third one will leave it to the ICU, be able to use it whatever they wanted to infuse in it. And this is a venogram, pulmonary venogram, or for the patient with large filling defect in the right and left pulmonary artery, as well as in the pulmonary trunk. And as I mentioned, we put in a catheter, will go all the way inside the main pulmonary artery, then to the left and to the right side. And then
recording in progress.
We'll leave a special kind of catheter to degrade the clots. So far we have done at least 61 or more cases in Westmead Hospital, and 1 death only in ICU wasn't because of the procedure, it was because of the failure of IV alteplase. So this is another device that we normally use it in, when we deal with PE, which is aspiration and suction. So we'll put in a big sheath inside the pulmonary circulation, and then we'll go as far as we can with the sheath, and then we'll use this wire to break down the clots, and then we'll use this catheter to suck the clots. And this is the device. We called it CAT-8. It's from Penumbra. So this is angiogram. See how far we can, put our catheter. So this is the right side circulation, subsegmental circulation. This is the left side, on the left side here. And we leave catheters there on the right and the left. So these are the dots for the ultrasound generation. And at the same time, we infuse alteplase. And this is the result that we got. We normally do baseline scan, and this bigger clots in the main pulmonary artery and subsegmental branches. This is the second day exam after the treatment. So almost complete resolution of the clots. And also you could see the difference between RV-LV ratio. It's a big difference. I remember this case when I was, just to start my career as IR. As a young patient, she was 19 years old only. She came in with, she has a complex heart surgery, and you could see there's a big tail catheter inside her chest, and she came in with the bigger clots in the subclavian vein. So I did venogram from the arm. You cannot see the subclavian vein here. And then I tried from the femoral vein, and also this complete occlusion. I managed to get my wire through the clots, and then I left this special catheter inside the subclavian vein, And this is the result next day. There's a good flow, and the patient completely asymptomatic and being discharged from the hospital a few days later. This is another example of bilateral pulmonary embolism. You can see the filling defects on both sides, and this is the second day after the treatment. Almost complete resolution of the right side clot with some residual on the left side, which is not significant. And this is how far we can go. This is subsegmental filling defects in the left side. This is after the treatment next day. And almost done. And this is the final slides, which I love these slides. So I finish with my talk. Thank you for your attention.
Thank you very much, Dr. Rafid.
Where do you want me to go? You have to book even more.
These are not my kids, so.
Thank you very much. I'm trying my best to mute the audience, but some of the colleagues are coming on the go. Thank you very much, Dr. Rafid. I will have to move to back to Victoria. So Dr. Farah Harawi is still with us. She's a consultant radiologist from McCallum Oncology Center in Melbourne. Dr. Farah will tell us about lung masses. Could you please share your screen with us? Dr. Rafid, could you unshare your screen, please? I can see your screen.
You can see it?
I can see it very clearly. Go ahead, Dr. Farah. Could you please introduce yourself as well? And we have 15 minutes, a big 15 minutes for you.
Yeah, I'll try and be very quick. Thank you very much for the association for inviting me to present, and also thank you for all the attendees on this Sunday evening. My name is Farah Harawi. I'm a consultant radiologist at Peter MacCallum Cancer Center, and I also work part-time at IMED Radiology Network. I'll be talking today about pulmonary nodules, why we care about them, and when and for how long do we follow them up. So a bit of introduction. So the why is easy. We're trying to find the nodules that eventually develop into cancers, and that's really the main thing we're trying to pick up. Now, as for when and for how long, that's quite controversial. There was always a bit of controversy. Some people recommend following up in 3 months, some in 12 months, some in 1 year, and some just ignore them. And as a result of that, guidelines were introduced. So I don't know, some people might have seen this being quoted on Radiology Report, the Fleischner guidelines. And this comes from the Fleischner Society, which basically, it compromises mainly radiologists, but there's also surgeons, pathologists, and physicians who are interested in lung imaging. And they came up with these guidelines in order to basically allow everyone to have something to guide them when we see these nodules for further follow-up. And the initial guidelines were in 2005 and 2013, and they were revised in 2017 and simplified. So these are the current guidelines, which I will be talking about today. And they differ from the older guidelines. They found out that we're basically following up too many nodules for too often. So they tried to simplify it, and they increased the size threshold. And they also now allow a range for follow-up. So they, instead of saying follow-up at 6 months, it's 6 to 12, to give people more leeway as to when they want to follow up, depending on the patient, their risk factor, and their preference. So these guidelines, we should always remember, these are for incidental nodules. So it's not for the high-risk patients who are heavy smokers, or patients who are known to have primary cancers. We do not apply them because these patients are more likely to have cancer than not. They're also for the younger patients, so they should be less than 35 years. And also we cannot apply them for immune compromise because these two categories are likely to have infections rather than nodules that are cancerous. So before we start, let's start with the nodules that we do not need to follow up and that we do not need to worry about. And the most common of these are the granulomas. So granuloma basically refers to an old granulomatous infection, usually childhood infection, most likely TB, and most likely asymptomatic. We see these all the time. They are very common. They're usually multiple, and the characteristic feature is that it has calcification. So you can see calcification at the center of this nodule. So whenever you see or hear a granuloma, calcified or not, you can ignore it. You do not need to follow this one up. And this is another example of one. This one's quite big. They're usually very small, and as I said, they're usually multiple. Another benign nodule is a hamartoma. Again, this is benign. It does not grow. It does not change into cancer. And what gives it away is usually very well circumscribed. It has, you can see this low density, that's fat, so it's got fat in it, and there's also calcification in it. And they vary in their appearance, but when we see all these three features, we know this is a hamartoma and we do not worry about it. So whenever you hear hamartoma, again, this is something you do not have to worry about or follow up. And the next one is the lymph node. So the lungs do have lymph nodes within them. Most of them are in the fissures, but sometimes they are intrapulmonary. And when we see a nodule that we think is a lymph node, what we do is we look at it in all three planes and decide what it looks like. And generally a lymph node, this is a more typical one. It's got a triangular shape or a faceted shape. So again, if you hear an intrapulmonary lymph node, we do not need to follow these up. And the other one is a scar. A scar is usually an area where there has been infection or treatment, and then it just scars into something linear. So again, this can look like a nodule in one plane, like here. And then when we look at it in another plane, we realize this is linear, it's a scar, and we do not need to worry about it. So I spent some time on these because I think these are more important than the other ones. Other benign nodules, of course, stability. So if I have an old CT, say 2010, 2015, from 5 years ago, and the nodule has been stable all this time, I know it's benign and it's unlikely to be something to worry about. Now, these are the guidelines, and for the interest of time, I'm going to just go through them quickly because I do not expect anyone to remember all these numbers, but it's just an explanation about what we do and why we do it. So they classify the nodules basically into two types. They are either solid or subsolid, and then for each category, then there's either single or multiple. So the first ones are the solid nodules. If it's less than 6 millimeters and the patient is low risk, then we don't follow up. If the patient is high risk, then we can do an optional CT at 12 months. And high risk, basically, usually if it's the nodule itself has suspicious margins, or it's an upper lobe nodule, or the patient is worried, or has got family history, then we can just do a 12-month CT for reassurance. If it's a bit larger than that, again, we do the first CT at 6 to 12 months and then another in the following year, just to make sure it's not growing. For larger nodules, once it gets more than 8 millimeters, most of the time it's big enough to be seen on a PET. So if we do have the PET availability, then we can either do a CT at 3 months or further assess it with a PET scan, which basically assesses the metabolic activity of this nodule. So once the nodule is larger, we don't just go by size, we also go by how it looks. So the appearance of the nodule rather than size alone is what should guide management. And this is an example of a nodule that looks very, very suspicious. It is solid, it's got spiculated margins, it's ugly, it's invading the surrounding parenchyma. So this nodule, even if it is small, I do not go by size alone, we go by how it looks. And this was an invasive adenocarcinoma. And this is a patient who's got a subpleural cyst, so these are not uncommon. And you can see here the patient had a CT of a year later, and it showed this nodular thickening of the wall of the cyst, and that's usually what adenocarcinoma does. It likes scars and cysts, and that's where it grows. So this was, again, an invasive adenocarcinoma. When we have multiple nodules that are non-calcified, again, if they're small, they're most likely going to be granulomas, and we do not need to follow them up. Or if the patient is at a higher risk or anxious, then we can do them at a follow-up CT, which is optional at 12 months. If they're more than 6 millimeters, then we do a CT at 3 to 6 months. And if they're still there, then we can do another one in the following year. So because in this case, we're really worried about metastasis, and metastases tend to be multiple nodules. They tend to be more than one size, not uniform, and they tend to be more peripheral, and they like the lower zones. So that's why we sometimes catch them at the bases of the lungs when we're doing a CT of the abdomen and pelvis. So you can see these are examples of metastases from a thyroid primary. They're multiple and they're different shapes and different sizes. Now, a subsolid nodule is also called a ground glass, or and I'll just show you the picture so to understand what we mean by that. So you can see through it. It's like crushed glass, and that's what we mean by ground glass nodule. It's not as solid as the other ones that I've just shown you. And these we worry about because adenocarcinoma looks like that. And adenocarcinoma is a cancer that's very indolent. It will stay there for a long time, and then suddenly it starts growing. And that's the reason we follow these nodules for many years. So in less than 6 millimeters, the guidelines say no routine follow-up, but some people do like to follow them up at 2 and 4 years, especially when it's closer to 6 or it has suspicious morphology. Once it gets to 6 millimeters, then we do follow up. We do follow up at 6 to 12 months, and then every 2 years until 5 years, for reason I just explained. So this is an example. So you can see this is a ground glass nodule. It's quite small, and at 15 months later, it hasn't grown. It's the same size, but maybe it's slightly more dense. Then we did another CT 10 months later. So this is 25, more than 2 years from the baseline. And that's when it started growing. It's got a more solid center, it's denser, and it's larger. And this was adenocarcinoma, again, on resection, surgical resection. This nodule, on the other hand, it does look suspicious. It's almost solid. It's irregular, but we followed it up, and this one actually disappeared. So it must have been like an infection or something benign. So it's tricky. Part solid nodules basically means it's ground glass, but it's also got a solid component. So it's a bit of both. And again, if it's small, we do not tend to follow them up. And once they get larger, we always go by the solid component, which is the bit that grows most. So again, we follow up 3 to 6 months, basically to see if it's still there, to rule out infection and other benign causes. And then we follow them up every year for a minimum of 5 years and sometimes longer. And again, if it's larger than that, we're a bit more worried. We follow up 3 to 6 months, and then we do a PET, CT, and a biopsy if it's still there or if it is growing. This is just another example of something that looks suspicious, but then it resolves. So that's why we do the first CT. The 3 to 6 month CT is basically to see if it's just infection, because infection can sometimes look a bit funny. And this is an example of a part solid. So that's what I meant by part solid. So you can see there's a dense bit, and then there is a bit that's ground glass. And at follow-up, although the size is not that different, but we can see that the white bit, the solid bit, it has grown. It's advancing. And that was also an adenocarcinoma. When we have multiple subsolid or ground glass nodules, we're worried again about adenocarcinoma because they also sometimes, for certain patients, tend to be multifocal, so they'll have more than one at the same time. So if they're small, then it's okay to follow up because people, oncologists don't tend to treat them until they're at a certain size because, as I said, they're very slow growing. So we do 3 to 6 months, and then we keep following them up until they're treatable. And if it's larger, then basically we just do it a bit more often, and then we consider multiple primary adenocarcinomas. And this is just an example of the same patient who's got 2 adenocarcinomas at the same time. And yeah, you can now see how they look. They look basically ground glass, and then they tend to have a slightly more solid center. So What are the risk factors for malignancy? So some of them are radiological. So we go by the size, the morphology, as I said, the margins, location. Cancers tend to like the upper lobes more than the lower lobes, multiplicity. If you have 1 to 4 nodules, your risk increases about beyond 4 after 5. If you have more than 5, apparently, then you're more likely to have granulomas. Of course, the quicker it grows, the worse it is. If you have a history of emphysema or lung fibrosis, you're more prone to cancer. Age increase, of course, the older you get, the higher the risk of cancer. Sex, actually, the adenocarcinoma is more common in non-smoking females, which is an interesting thing. Race, so it's more in African Americans, and a family history, tobacco and inhaled carcinogens such as asbestos increases your risk for lung cancer. And there's just another slide to show the higher risk is older age, heavy smoking, large nodule size, speculation, and upper lobe location. So take-home messages. We should always remember the guidelines should only be used when they are incidental. So it's not for the high-risk population or for the patients less than 35 years. Benign nodules are the granulomas, granulomatous, hamartomas, lymph nodes, and focal scars. Adenocarcinomas are indolent, they're slow growing, and that explains why we follow them up for so long. If we have older imaging, if you know the patient has had imaging elsewhere a long time ago, it's very crucial that we get it, because then we can basically sometimes get away without following up if something's been stable for a long time. And this is not maybe very relevant, but if you really think if you're worried a patient has got cancer, if they're heavy smokers, they've got a strong family history, don't do a chest x-ray, just go to a CT. Small cancers can be missed on chest x-ray, but CT is a very good test, and it doesn't involve a lot of radiation, and we can even do it non-contrastively. Don't need to give contrast, and it's very safe. Thank you very much.
Thank you, Dr. Farah.
Thank you, Dr. Farah. Thank you very much. Very nice presentation. So I think we do have a few minutes for some questions. I can see that the speakers have answered a couple of them. Thank you so much. And perhaps I'll start with the first question to Dr. Wassal. If you can, perhaps the speakers would unmute if possible, please, so they can share the answers. The question to Dr. Wassal, can a lady refer herself for a mammogram? Do they need a GP referral?
Well, it depends if it's a screening or mammography or diagnostic. For screening, of course, you can go for screening without referral. But if you're coming for a diagnostic one, then definitely you need a referral. Otherwise, Medicare is not going to pay for it. So you can't get repaid without a history. And so sometimes they send them with just a breast lump, question mark, or pain, or what have you. But we need definitely a history to do the diagnostic one. And there was another question about can screening do 3D mammography? Yes, a lot of the big centers for screening that now they do 3D mammography, especially in hospitals and teaching hospitals. But now everybody is leaning more toward the 3D tomosynthesis.
Thank you very much. And there's another question that, some centers now offering simultaneous mammogram and ultrasound simultaneously, thinking that the specificity sensitivity is higher. Do you agree with that?
Absolutely. I never do mammogram without ultrasound, because the missing rate for mammogram alone is 8 to 10%. When you combine mammogram and ultrasound, it goes down to 3 to 5%. So it's a big, and it's really very important. I showed you a couple of examples. You can see a well-circumscribed lesion on the mammogram, and when you do ultrasound, then it could be either a cyst, or it could be phylloides, or it could be medullary tumor, or it could be so mammogram by itself. It is very good for picking lesion, but ultrasound is good for characterizing that lesion further.
And that can be done at the same session, like the lady would come for a one visit.
Again, it depends if it's a screening thing or if it's a diagnostic thing. If it's a screening, then the two radiologists agree there is an abnormality, they call the patient back, they do the ultrasound, and they examine the patient. In diagnostic, I definitely all the time do it together. Whenever there is an abnormality, because we do the ultrasound tailored to the mammogram finding. So we find something in the mammogram and we specifically do the ultrasound for this area to have a look. And myself, I go in, I examine the patient as well, I take the history. So it's much more actually rewarding for the radiologist to be there, see the patient, do the ultrasound myself. I talk to the patient if there's an abnormality, if she needs biopsy. So it all be sorted at the same time.
Thank you very kindly. Thank you very much. I can see some questions being answered, but it has interested me, the question from Dr. Amelia from Melbourne about pregnancy and say thromboembolic complication. Perhaps a question to Dr. Rafid. Could you please, or any of our colleagues, explain to us the concept of shielding during pregnancy, whether the patient have a suspected, say, CVD stone or a suspected PE or a trauma, and we need to perform a CT scan. Is it still applicable nowadays? Can we have an update, please?
Anyone want to answer? Me? Okay. So
yeah, go ahead, please. Yeah.
When it comes to the pregnancy, it's too complex to deal with this kind of these patients. We do normally do shielding, okay? And for example, for PE, we prefer to do VQ scan. VQ scan has a radiation dose, but much smaller than compared to the PE. But, CTPA. But CTPA will give you accurate details and sometimes just, exclude PE. Yes, when we do use shielding, we minimize the risk of radiation, but still there's radiation hazard, much smaller without shielding. And also, for example, I deal with many patients. They come in with they're pregnant, or they come in with the trauma, or they come with the PE in angio suite. So we do have certain parameter to reduce the radiation dose, like bring the camera close to the patient, and also lift the table higher. We'll keep the radiation dose on low dose. So we're minimizing, but we're not eliminating all the radiation hazard.
Can an MRI suffice, replace the CT scan in this situation?
It can, but I don't think so. It's available in every center. So, and also MRI, most of the PE cases, they come in the night time, most of them, I don't know why. And the service of MRI is not available 24 hours. They call on call people, but again, the MRI won't give you a definite answer.
Because of breaking up.
Yeah, unless the PE is big.
I just have one comment on the issue with the general DVT and PE in pregnancy. Even if you are suspecting PE, if it's coming from general practice or an emergency department, I think the first step is to see whether the patient has leg symptoms. If they have leg symptoms, we tend to do a bilateral leg Doppler. If they have a DVT in the legs, then you haven't used radiation, you know there is a clot, you start the treatment. You don't need to image the chest in any modality. If they don't have leg symptoms, you start with a chest x-ray. And you use the shielding and you do just a frontal chest x-ray. If the chest x-ray is clear, a VQ scan is the next step, because you know that the lungs are not going to be degraded by any artifact from atelectasis or consolidation. So the quality of the VQ scan will be good. If they have an opacity on the chest x-ray, then you're either dealing with an alternative diagnosis to PE, such as pneumonia, or you're dealing with something, a radiological issue related to PE, such as an infarction or ischemia. And then you proceed to a CTPA. I think that this is the protocol in our hospital, and it may be different from one hospital to another, but at least in 2 different hospitals in Melbourne, that's the same protocol that we follow. And I think Farah knows about the protocol, and I suspect that they use something similar like Peter Mac and IMED networks.
Thank you very much. Perhaps go ahead, please.
Question, Dr. Jafar. No, we have a question from Dr. Jafar. Can you read it?
I can.
On the chat.
All right. Well, we'll try to find this. There's quite a few from our colleagues coming, but I'll certainly try to find it. While we're finding it, perhaps I would ask Dr. Farah a question. Was so interesting to say that the upper lobe lumps, lung masses by themselves are considered high risk, which I do agree. I see that in metastasis from abdominal surgery. Why are they high risk? Why there's a predilection for the cancer nodules to settle in the right lobe? Is that an anatomical factor?
I don't know the answer to that. It's just, I think it's a statistical thing. I'm not sure. Sorry.
No problem at all. And the second question, that in a peripheral suspicious solid lung nodule, would you admit the patient to the hospital for the risk of pneumothorax associated lung biopsy, or you happy in your center just to do an outpatient lung biopsy, for example?
So lung biopsies would will always have to be in a hospital setting or a place where there is like services for anesthesia if required. What we do is we make sure the patient knows that they're going to be in hospital for at least 4 hours. We do the biopsy and we put them in the recovery area, and we do the chest X-ray at 4 hours. If they do have a pneumothorax, then we contact the thoracics team and admit the patient.
Sure.
But yeah, we definitely let them know that it is a risk. Not whether it's peripheral or central, there's always that risk.
Absolutely. Thank you. Dr. Ahmed.
Can I comment
Go ahead,
on the
please.
lung biopsy? Because probably every hospital has different protocol. In Westmead, we do book in lung biopsies as outpatient in the morning session, and we'll keep them, maximum in 4 hours. We'll do 1 or 2 chest X-ray to make sure that there's no pneumothorax, and then we'll discharge the patient. There is a small risk of delayed pneumothorax. We notify the patient if they have any chest pain, anything, they come in directly to the emergency, and they, tell them that I had a pneumothorax done in this morning. I had a lung biopsy done in the morning, so I might have pneumothorax. We do that because of the bed crisis. As you're aware, we don't have enough bed to accommodate all the patients. And if the patient is high risk comorbidities, we do it as inpatient.
Thank you very much. Dr. Ahmed, unfortunately, I cannot find. Yeah, go ahead, please.
Well, we have a question from UK. From our colleague Yusar Jafar, a consultant breast radiologist. And I think the question is directed to Dr. Wisal Al-Musawi about her thoughts on personalized breast screening in Australia. Do you have any thought about the personalized breast screening, Dr. Wisal?
You mean like patient referring themselves? When you say personalized, patient referring themselves, yes, there is, because wherever you go, there is the vans, the breast screening vans, and there is you can call any breast screening center and book yourself in. And once you book yourself for the first time, regularly every 2 years, they will send you a letter and you say you'll be due for your next breast screening. So that's how it works here. So yes, you can call any screening center.
Yep.
Thank you. Thank you very much.
I have 2 questions.
Go ahead, please.
Can I ask? Yep. I have a question to Dr. Norman. Do you have any comparison between MRI and CT scan of the spine in terms of specificity and sensitivity? Dr. Norman.
Yes, so the issue of sensitivity and specificity for spine imaging really relies on what the outcome you are trying to measure. So the issue with spine imaging is that unlike, for example, a chest CT for pulmonary nodules, the outcome is histopathology of the pulmonary nodule. So you can have a reference standard, which is histopathology. In spine imaging, your reference standard is always patient's symptoms. You can have a CT scan, you can have an MRI scan, you can have an X-ray, all showing some changes. And you can have an MRI scan showing nerve root compression, but the sensitivity and the specificity will be zero if the patient's symptoms do not exist, if the patient is asymptomatic. What I can tell you for sure is that in terms of visualization of structures, so such as the nerve root itself, the MRI is obviously much better. And in terms of visualization of the disc and the disc material in the spinal canal and the cord itself, the MRI is much better. This is provided that the patient can have an MRI. Some patients cannot have MRIs for claustrophobia or pacemakers or metalware, and provided that the patient can lie still. If you're dealing with a patient with a lot of pain, they may not lie still. The MRI will be motion degraded. You're not going to have interpretable images. And a CT scan, which takes a few seconds, will probably be much better in this case. So it's all variable depending on what you want to measure as an outcome. And in the spine, the outcome is variable. The outcome relies on patients' reported symptoms and clinical examination findings.
Thank you.
Mohammed, I'm sorry it's late, but just have a question to
Go ahead.
Dr. Rafid. And there is about probably a half-minute question to Dr. Wissal. For Dr. Rafid, the D-dimer is a poor test. And I'm surprised that it is in your algorithm or protocol for the probability of PE. I think arterial blood gas would be more specific differentiating test than the D-dimer. The specificity of 50% is a poor specificity. So can you comment on that, Dr. Rafi?
Yeah, I totally agree with you, Dr. Ahmed, but they do it routinely in ED. Any patient coming with suspicion of P, they do D-dimer. Yeah, I do agree with you. I will investigate more about this, but we routinely do D-dimer. Probably not available in ED, or probably time consuming. I don't know what's going on in ED, but most of the patients, they come in either from ED or from the ward. After consultation with the respiratory physician, they consult us whenever they image the patient and the patient to prove to have B on imaging. But I'll ask more about this and then I'll let you know.
Thank you. Thank you very much. Dr. Wissal,
Yes.
we have a few cases of positive breast cancer with a negative mammogram and ultrasound 6 months earlier. I have personally patients with breast cancer diagnosed. They come to me for a variety of other reasons, but they both have
the line is
mammogram, negative mammogram, a negative mammogram and ultrasound. 6 months later, there is a positive breast cancer on a repeat mammogram. Can you break this gap by another test like MRI? Can you do MRI with high risk?
Okay, so I thought the question was, is sometimes you can have a negative mammogram, negative ultrasound, and then 6 months later, the patient presents with a cancer. Is that the question? And is there another modality? Okay, yeah, sure. As I said at the beginning, if you do mammogram by itself, the risk of missing cancer is 8 to 10%. If you do mammogram and ultrasound, you still have a risk of around 3% of missing cancer. Some cancer are very fast growing, and if you do it with a really dense breast, settled cancer, it's easy to miss it. Not easy, but if they settle, and if the breast is very dense, and if it's only microcalcification, then you can miss them. And that's why MRI is superior to combined mammogram and breast ultrasound in detecting small, early, and fast-growing tumors. So MRI is the answer. And if you're doing a screening mammography in a high-risk patient, you usually do it on a yearly basis. If you do MRI, you don't need to do it on a yearly basis. So you do one this year, one next year, and if both years are negative, then you can do it every 2 years or every 3 years. So MRI is superior to a combined mammogram and ultrasound. Of course, MRI with contrast, MRI breast with contrast, with gadolinium.
Excellent. Thank you very much. Dr. Ahmed, do you have more questions to the team?
have a question, please.
All right. Go ahead. Go ahead, please. We can hear you. Go ahead.
For me?
Yes, please. Yes, please. Go ahead.
Thank you very much. In 1979, I had a research with Dr. Amjad Naimi about the breast cancer. At that time, the number of the patients who have breast cancer was nothing compared with the high percentage nowadays. Is the main reason was, or is the radiation or the radioisotope pump that used in 2003, and how can we help? Because I hear that a lot of the patients who have breast cancer now, and they increase the number. Can we have any resolution or solve or help for them? My question for anyone, please, any lecturer.
Well, as I
Thank
mentioned,
you very much.
I mentioned my risk factors, that radiation is a risk factor. The reason why we're having more numbers now, also a big factor for that is imaging is much better. Like 3D has increased detection of early breast cancer by 20 to 30%, which is huge. MRI has increased the detection rate dramatically using gadolinium as well. So new technology, advanced technology, more people are more involved in training programs and more specialized breast imaging radiologists. So that's a big factor. So the other part, yes, radiation can increase the risk as one of the factors. What can we do? What can we help? We can just run through screening programs. We have to educate people about the importance of screening mammography, and we have to make it available to patients. That's the most important thing. Nothing else will work. Screening mammography, that's what they need to do. And it's available in Iraq. It's nothing expensive, like a mammogram machine. It's not an expensive machine. They have a lot of CTs and MRI. Every practice, a radiology practice will have a mammography and an ultrasound. So we can offer it to population, and that's the only way to detect early cancers.
Dr. Mohammed, last question, Dr. Rafid.
Go ahead.
Dr. Rafid, how many hours after the diagnosis of PE or the onset of symptoms that intervention can be feasible? Is there a duration where you cannot do it anymore?
Yeah, with chronic PE, you can't do much because it's already organized, but with kind of acute and subacute PE, the answer yes. I would say if a week time or more, then the intervention will have less value.
Thank you.
Thank you. Thank you to everyone. I think just for the time limitation, it's 20 to 10. I personally enjoyed it significantly and learned a lot, as always. I would thank all of our presenters and the audience for a wonderful webinar. And if there is no more comments or questions, I may then call a close to the webinar. And once again, grateful to the help and the efforts from all our experts and consultant radiologists from Victoria and Sydney. Thank you to everyone.
Thank you very much for the questions. Thanks. Good to
Thank
see
you all. Thank you, guys. Thank you.
Yeah,
have a
thank
good
you
night.
very much. All the best. Have a good night. Thank you so much.
Thank you.
Stay safe.
Stay safe. Stay vaccinated.
Exactly.